Once we're continuing with active vulgaris with the multiple disorders and we go through diabetes and endocrinology. Acting vulgaris may begin 1 to 2 days before the onset of puberty, following androgenic stimulation of species glands and an increase in menstruation rate, option to close sebum ratios, follicles, initiate the process of acne. The mission of focusing on a variety of lesions, especially open comedones, blackheads, closed comedones, whiteheads, progressive papules, pustules, nodules, and cysts. Lesions appear mainly on the face, back, chest, and the shoulders. Most severe cystic and nodular lesions often produce scarring, menstruation, and emotional stress, maybe social exacerbation. The condition usually resolves in the late teens or the persists. Topical treatment is targeted at anti-anxiety discomfort. Same therapeutic agents such as benzoyl peroxide, advanced across the battery, sunshine inhalation, topical antibiotics, or topical retinoids may be helpful. For most severe acne, antibiotic therapy rejects cyclines only when more than 12 days old because the may discolor easily in children or it's a lysine is indicated. The oral retinoid axoretinoid serves severe acne in young people and responsive to other treatments, rash with systemic diseases, and rash with systemic disease. Examples are facial laceration, dermatomyositis, purpura ovipodox, limonene showing purpura, erythema nodosum, and erythema. Both can be associated with systemic disorder, but often no causes side effects. So the choice of syndrome ratio limited to extensive skin involvement, involvement just membranes, and often starts with an upperized often slightly tract infection and involvement with conjunctivitis, cornea sedation, mellitus, and a terminological assessment is required. It may be caused by drug sensitivity, infection of both morbidity, and sometimes even mortality from sepsis or the electrolyte imbalance. Edema nososum, there are tendon nodules over the legs. She also had fever and trachea. Causes septal infection, primary tuberculosis, inflammatory bowel disease, drug deaths, and developing sarcoidosis, common restriction, severe children. Edema multiform. Edema multiform with dark associations with a central papule surrounded by a religious ring. And lesions may also be vesicular. Mucous membranes liquid wall as shown by this noise, ulceration, conservative multiform herpes, mycoplasma pneumonia, and infection drug reactions and idiopathic. Stephen Johnson's infection, severe projectile isolation of the urticaria heights, characterized by fresh colored wheels with the averaging anaphylaxis. Papular urticaria is a delayed hypersensitivity reaction most commonly seen on the legs, involving a bite from a flea, bed bug, animal, or bird mite. Irritation of papules and wheals appear as secondary infection due to stretching is common, may last for weeks or months and may be recurrent. Hereditary angioedema is a rare autosomal dominant disorder caused by deficiency of dysfunctional C1 esterase inhibitor. There is no urticaria, but the subcutaneous swelling occurs, often accompanied by abdominal pain. The trigger is usually physical trauma, psychological stress. Most episodes develop over a few hours and subside in a few days, and angioedema may cause respiratory obstruction. And now we do endocrinology, diabetes mellitus, and features of diabetes endocrinology. Children, diabetes keeping blood glucose levels close to the normal range reduces the risk of long-term complications with diabetic ketoacidosis can be minimized by following national guidelines. The growth, activity, and pivotal development of children. Excuse me, sorry. Pivotal development children and adolescents. It also make it more difficult to maintain blood glucose levels in normal range, congenital hepatitis, and multiple unrelated blood spot screening. Growth hormone treatment is recommended for growth hormone deficiency and a number of specific conditions when treatment increases final height. Adrenal dysfunction may present with hypertension, hypoglycemia, hyponatremia as a medical emergency. Diabetes mellitus, there are under 30,000 children and young people under the age of 90 years with diabetes in England. and bears equivalence of 2.5 per thousand in 1 to 2 secondary school incidence has increased over the last several years, most likely in traces beyond that. So risk factors will exclude understood almost all 95% children have type 1 diabetes requiring insulin from the outset. Although type 2 diabetes is increasing in childhood as obesity becomes more common, as a cause of diabetes are listed, most children have a type 1 and type 2, the number of diabetes increasing. Classification of diabetes according to etiology, type 1 most childhood diabetes structure for cardiac beta cells by an autoimmune process. Type 2 insulin resistance followed later by beta cell. Usually older children history related positive family history not as strong with these process. More common is something with fragmentation tools, more general diabetes maturity, onset diabetes at a young, various sites caused by genetic defects in beta cell function, strong family stimulated diabetes, transient permanent secondary to infected beta cell function, drug-induced corticosteroids, pancreatic insufficiency, 65 years ago, related thalassemia, endocrine disorder, Cushing's syndrome, gestational diabetes. Etiology of type 1. This is genetic predisposition to developing type 1 diabetes. Immune activation may trigger an immune response, autoimmune response, process in susceptible individual which damage the pancreatic beta cells and leads to increasing insulin deficiency. Recognized autoantibodies include glutamic acid, decarboxylase, zinc transporter 8, and islet interferon 2. Identification of more than one of these autoantibodies have been shown to be associated with potential to develop clinical diabetes mellitus susceptibility in customers. By twins have a high risk of developing diabetes mellitus compared to other siblings. This is genetic risk, immune activation, autoimmune iron cell destructions. Version 2 autoantibodies that indicators of glycosuria, bronchoamine, glycosuria happens, and then diabetic ketosis. This is the stages in development of diabetes. Approximately 70% risk of developing diabetes within 3 years and a twin compared to 15 risk in RCA. There is an association with other autoimmune disorders such as hypothyroidism, Edison disease, celiac disease, and rheumatoid arthritis, depression, and family. Diabetes is also more common in children with Down and Turner syndrome. Clinical features, there are peaks of presentation of type 1 diabetes in spring and autumn months. In contrast to adults, children usually present with only a few weeks of polyuria, excessive thirst, polydipsia, and weight loss. Diagnosis at an early stage of illness is important in order to prevent development of the diabetic research. Ketoacidosis is referred to a specialist team should be done as soon as the diagnosis is suspected. Diabetic ketoacidosis requires urgent recognition and treatment as it carries significant risk of mortality in children and young people. It is easily misdiagnosed if rapid breathing is mistaken for pneumonia or abdominal pain for appendicitis or constipation. Diagnosis is usually confirmed in a symptomatic child by finding markedly raised random blood glucose note in 11.1 millimole by the current appearance definition of glycosuria ketosis. Where there is any doubt that fasting blood sugar more than 700 raised glycosylated in the way students are helpful. Children and young people with type 2 diabetes may have similar symptoms to those with type 1. However, the diagnosis of type 2 diabetes should be considered if there is a positive family history and in obese children with signs of insulin-resistant acanthosis, negligence, velvety dark skin on the neck or armpits, skin tags, or the polycystic ovary phenotype in males and females. Whereas a diagnostic glucose tolerance test is really required to diagnose type 1 diabetes in children and may be necessary for type 2 diabetes. Symptoms and signs early, most common classical type, associated with polydipsia, polyuria, weight loss, is common. Secondary anemia, sections, candidates, late diabetes, ketoacidosis, DKA, smell of acetone, breath, vomiting, dehydration, abdominal pain, rapid breathing, deactivated with small breathing, hypovolemic shock, drowsiness, and reduced level of consciousness. Initial manual type 1 as type 1 diabetes challenges uncommon much of the initial routine care is delivered by specialist teams. Initial management will depend on a child's clinical condition. Those presenting with diabetic ketoacidosis require IV treatments and high dependency care. Most newly presented children are alert, are able to eat and drink, and can be managed with substitute insulin with brief hospital admission. Fibrosis and exercise sign of insulin resistance. Diabetic team consult physician with special interest in diabetes, pediatric diabetes specialist nurse, pediatric dietitian, clinical psychologist, social worker, youth worker, 3 specialists, adult diabetes for transition clinics, parent patient support groups. An intensive education program is needed for the care of a child. Information provided must be prepared for age, including a basic understanding of the pathophysiology of diabetes, injection of insulin, techniques in size, blood glucose, fingerprint monitoring to allow insulin adjustment, blood free tone monitoring when unwell, healthy diet same as for diabetes, aiming for a minimum of 5% of fruit and vegetable per day. Carbohydrate content should be taught from diagnosis, encouragement to exercise regularly with adjustment of carbohydrate insulin for exercise, sick day rules during intercurrent illness to prevent ketoacidosis. Recognition stage treatment of hypoglycemia, way to get advice 24 hours a day. The help available from voluntary groups, local groups at Diabetes UK, the psychological impact of a lifelong condition with potentially serious short-term and long-term complication. Diagnosis of diabetes is life-changing and many families grieve for the loss of their previous lives, especially financial lies with the school teachers, those who prepare school meals, physical education supervisors, and the primary care team so that the child is well supported in all environments. Insulin regimen, different types of insulin also people think of. So we will do this. Insulin regimen aims to mimic normal physiological secretion of insulin responsible to insulin release from the pancreas spontaneously, which surges when blood glucose rises following carbohydrate ingestion. This requires intensive insulin regimens, which have been shown to reduce the risk of long-term harm. Therapeutic insulin produced for recombinant DNA technology to be similar to human insulin, different types designed to beat up the short long-acting insulin can be given as multiple daily injection, basal bolus, where rapid acting is given bolus before each meal plus a long-acting insulin in the evening and or before breakfast to provide background insulin basal. Insulin is injected into subcutaneous tissue on the anterior and lateral aspects of the thigh. The buttocks or the abdomen. Rotational injection site is essential when hypothesis. Alternatives insulin and women continuous subcutaneous insulin pharmacies. If small doses of rapid-acting insulin are delivered continuously in addition to the program for each meal or snack. These regimens allow flexibility by relating the no closer to food intake and exercise. Patients' families are taught to aim for blood glucose between 4 and 7 before meals. If the blood glucose is high, additional rapid-acting insulin is given at meal times to correct it to the target range. Input requirement by the child, family, and team to initiate or maintain these intensive regimens is high. Shortly after this rotation, when subpancreatic function is preserved, insulin requirements often becomes in the so-called honeymoon period. Requirements typically increase to 0.5 units per kg per day to 1 unit per kg per day, even up to 2 units per kg per day during puberty. So this list for rapid-acting insulin onset is 15-20 minutes, peak action is 22 hours, 3 to 6 hours duration of action. Listo, Imlog, no rapid, and glycine, Epidra, short-acting, ectoplasmic human S. 30 to 60 minute onset of action, peak action is 2 to 4 hours, and duration of action is 8 hours. And long-acting insulin analogs, ketamine, levonorgestrone, and Lexudec is 1 to 2 hours, peak action up to 24 hours. This is basal bolus regimen, breakfast, lunch, midnight breakfast, lunch, dinner, bedtime, continuous subcutaneous insulin injection, breakfast, snack, lunch, dinner, bedtime, blue. 3 times rapid acting insulin, blue, and 1 long acting insulin by injection each 24 hours, continuous subcutaneous infusion, quick acting, delivered at the program rate, being depending on requirements of bolus blue, delivered at many times. Factors affecting blood glucose level increase, glucose, insufficient insulin, food, especially carbs, illness, menstruation, shortly, full onset growth hormone, corticosteroid, sex hormones, overweight, and stress, decrease, insulin, exercise, alcohol, some drugs marked, anxiety, excitement, and hot Whether diet, children and young people with diabetes mellitus are encouraged to eat a healthy diet. The aim is to maintain normal growth while maintaining normal blood glucose levels by matching insulin to carbs intake. The diet should be high in fiber, which will provide sustained release of glucose rather than refined carbohydrate, which causes rapid swing in glucose levels. Carbohydrate counting allows one to match the insulin dose to the choice of food, also taking into account the pre-meal glucose levels and post-meal exercise pattern. Blood glucose monitoring, regular blood glucose measurements are required to adjust the insulin doses and learn how changes in lifestyle, food, and exercise affect glucose levels. Learning this balancing act requires considerable educational input followed by refinement in light of experience. National guidelines recommend a minimum of 5 blood glucose tests each day, with some using intensive monitoring of 8 blood glucose tests a day. Record the record should be kept entirely transferred from the memory of the blood glucose meter for ease and accuracy. Data can be displayed in graphic format, allowing easier analysis. The aim is to maintain blood glucose as near to normal as possible, but this can be extremely difficult. Listed goals need to be agreed with each individual. Blood glucose monitoring case history. This is diary of 8-year-old with type 1 diabetes experiencing carbohydrate counting for all meals, but this can be difficult when eating unfamiliar foods. August blood glucose rises to 11.8. He uses correction doses if his blood glucose is high before meals, using 1 unit more rapid to bring his blood glucose down to approximately 4. July 29 from 9:30 before breakfast to 6:09 before lunch. Please reduces his rapid acting insulin before predictable spot to reduce the risk of hypoglycemia. Pre-lunch in August 2. Insulin high glucose on bracket challenge expected from previous stages. 4 breakfast 2 hours, 4 lunch 2 hours, 4 before tea. As good recognition of symptoms of glycolysis intrinsic no established than a snack, his blood glucose levels sometimes overshoots after treatment, having the same blood glucose low after physical exercise, high after treatment on August 6. When his ML on his blood glucose levels and especially high, he checks for blood ketones and give extra no as keeping a diary for someone risk. One may be unreliable. They have largely been replaced by blood glucose meter upwards. All within target range and this is a diary flash glucose monitoring system. I usually watch it when young people require that monitoring glucose is made. It is a shift fluid by a small sensor which can be scanned to show glucose. It warns if the glucose is rapidly decreasing. Small quantities of carbs are required when increasing exercise is needed. Continuous glucose monitoring use sub-Q sensors to provide continuous reading of blood glucose. Sensor data can be used remotely on a mobile phone to support general triggers. Technology like CGM pumps to help control the insulin delivery from pumps, expanding insulin delivery when anticipating hypoglycemia and increasing days of delivery when glucose levels are high. Hybrid closed loop pumps. Continuous glucose monitoring are particularly useful to detect asymptomatic episodes of hypoglycemia or high glucose levels after meals as they allow when approaching low or high levels. Blood ketone testing, often using the same meter as for blood glucose material illness recognized the avoid ketoacidosis. The measurement of glycolysis experience is helpful as an indication of diabetes care over the previous 6 to 12 weeks and should be checked at least 4 times per year. The risk of developing later complication increases if the level of HbA1c is persistently above target. Reducing level maybe breastfeeding the red cell lifespan is reduced, such as in sickle cell trait, or if HbA molecule is abnormal as in thalassemia. Example of flash glucose meter sensor is inserted sub-Q and determine in the determines the glucose levels in the gestation fluid, which is scanned periodically with the reader of mobile phone, shows the glucose reading trend over the number of hours. Example data from a flash glucose monitor read of glucose at various times of day. The orange line shows the average glucose over 2 period. Dark blue shaded shows 50% glucose recording in that, and there's a considerable variability throughout the day, except where the line narrow at 10. Continuous CGM monitors send data directly from a sensor to manual monitor pump and can provide alerts for high and low glucose and need to be calibrated regularly and the sensor replaced after 7 days. Example of data from CGM showing average blood glucose levels throughout a 24-hour period. Keeping also within the target range for more than 70% of the time associated with HbA1c in their target range. Acute complications. Hypoglycemia. It is inevitable that children and people who manage diabetes well will experience episodes of hypoglycemia, often called hypos. This is defined as someone with diabetes mellitus as a blood glucose below the millimole per liter. Symptoms of hypoglycemia are highly individual and change with time, but most complain of hunger and unsettled stomach, sweatiness, feeling faint, dizzy, and wobbly in the legs. Fine recognized untreated symptoms may progress to loss of consciousness, seizures. Parents can often detect hypoglycemia children by the pale and changing behavior suspected. Blood glucose levels should be checked. Frequent episodes can associate with loss of awareness or symptoms should be avoided. Treating hypo in early stage requires administration of easily absorbed glucose in the form of glucose tablets should be drink glucosade, and children should always have easy access to the hypo remedy, although young children may learn to complain of hypo symptoms. In order to leave class or obtain a sweet drink, or glucose gels are absorbed from the blood mucosa and are helpful if the child is unable to cooperate. It can be misdone by teachers or other helpers following treatment. Following treatment, the child should no. It can be listened by teachers or other helpers. Following treatment, the child usually should have slowly absorbed carbohydrate, for example, fruit or a biscuit to prevent the blood glucose dropping. Again, parents and school staff should be provided with a glucagon injection kit for treatment of severe hypos to reduce level of consciousness and thought has an instant hospital. The child is unconscious, not to hospital. Hypoglycemia treated with 2 per ml kg of intra 10%, IV 10% glucose. Severe hypoglycemia can usually be explained by misleading exercise aim in is anticipation of prevention, for example, that reducing residual dose prior to planned exercise, DKA presentations of side talks, session investigations, and measurement. Essential investigation diabetes blood glucose model 11, ketone model 3, blood gas analysis, metabolic cirrhosis, pH less than 7.3, plasma carbohydrates less than 16, urinary electrolyte treatment 25, dehydration, evidence of these are the all the investigations of these are A, evidence of precipitating cause, infection, bad immune culture, perform cardiac morbidity, weight changes, hypoclemia, weight, compared with recent clinical weight with certain accessibility, blood class, more than 7.2 or by 10 to 15, mild decay, 7.1, 7.2, by 5 to 10, moderate decay, my pH less than by less than 5, severity do not get by correct acidosis. Emergency measures qualified administer oxygen and shock with tachycardia, deep feeding passes, and poor secondary vision give bonus 20 and amputation 0.9%. NaCl Consider IV antibiotics suspected substitute VA. If not to chalk, the initial bonus of 10 ml per kg, 0.9% NSAID. These are fluids that are given severity and also measures and fluids and dehydration pH is less than 10% dehydration. More than 5% dehydrated. Give hydration fluid over 48 hours. Mellitus will start with for 9% with 20 mmol KCl per 50 ml. Backward measurement contribution. The one after addition start IV insulin infusion at 0.05 units per kg are considered doubling rate in severe DKA. Glucose, potassium, sodium, and conscious levels. These are monitored. Insulin is given fluids and then monitored. Was less than 14, pain fluids to 5%, glucose by 9%, NaCl 20, mmol KCl 5 primary production test, serum electrolytes normally maintain our serum pressure levels, KCl. This may require central line, high glucose levels draw water by osmosis. This may serum sodium failure, conscious level GCS. Regular usage of GCS less than 15 ml per kg, IV 2.7% may see 1 gram per liter. Mannitol decays only resolved when battery doses are low, not when glucose are normal. Insulin decreases production as well as glucose, increasing risk of cardiac disturbance. Haplotype increasing risk of cellular cellular deposit default in DKA and normalize. When pH in the decline normals to subcu insulin or diet stop IV insulin infusion 1 hour after giving subcu insulin as it takes time to be absorbed. These were nice guidelines. Such things. No, these were not nice guidelines. I think these are severe relation because of the weekend for most people. These are the pictures. Long-term complication of diabetes and the complications present during childhood, but management diabetes in children and young people aim to at reducing the risk of complications. Microvascular hypertension, chronic heart disease, cerebrovascular, microvascular nephropathy. It has been shown that meticulous diabetes cares delays or prevents microvascular complications like retinopathy occurs, keeping blood glucose levels essentially the significant target values can slow its progression. There is also evidence that having HbA1c within target early in diabetes reduces risk of later complications even if the HbA1c deteriorates later in life. Levels of HbA1c above the upper limit normal 48 millimole per mole, 6.5%. And related to risk of later complication in a normal exponential fashion. So the ideal is to aim for a level as close to the level someone without diabetes is possible. As is aimed at difficult to achieve in all patients at all stages of their condition, children and their families should be reviewed regularly to assess their diabetes care to monitor development of population to ensure that they have age appropriate progression in that cycle. Social aspects are addressed. Regular assessment of child assessment diabetes, any episode of hypoglycemia, diabetic ketosis, hospitalizations, there's still awareness of hypoglycemia, access of schools, school supporters of diabetes care, interference with normal life usually results less than 48 minimum per mole, 6.5%. And review the diary of blood glucose results of glucose, detail uploads, and appropriate actions result when taken into the measurement appropriate hypertrophy and laboratory of injection fine diet. Healthy diet manipulating food intake and may join a reduced periodic difficulty. When avoiding recipe may high degree of BMI important by shot at each clinical visit. Blood pressure check for hypertension and belief for 12 hours, failure speech, is specific sanitize, unit disease for microbiome and recent probably and belief from 12 years. Circulation check for pulses and sensations. Retinopathy of cataracts are in children, but should be monitored annually from 12 years, preferably with retinal photography. Feed maintain good care about tight shoes and avoid being prone to treatment of infections annually. Screening for severe and high disease diagnosis with virus can be manually select again for symptomatic and a reminder to have two accession and seek dentist. Now, in the psychosocial aspect, good understanding diabetes, good participation when it is natural and diabetes beneficial, member diabetes UK, uh, becoming self-reliant by appropriate supervision at home, school diabetes team, taking exercise food that is not interfering with it, leading life as normal as possible. Is hypertreatment readily available? Is step to is known? What are the main issues for patients? Are there short-term goals in their sufficient to include glucose, the regular assessment of child or young children, injection sign, check for injection use and injection size of the individual, aspects of leg and abdomen, lipohypertrophy of bone from injections. These are type of diabetes in normal. Noticing normal reducing dilation, parasitic like insulin resistance secondary to growth sex hormone secretions, growth in related delayed diabetes controlled manner, psychosocial reduce self-feeling to impaired body image to close compares, social difference of view with need for blood tests, injection, hypoglycemic events, can be fighting with side difference from friends, increased risk of alcohol, smoking, use of recreational drugs, facial plants restricted, heavy food, heavy players, scarlet, separation from parents more complex. Diabetes is a devastating diagnosis and usually with imaginary the children and people are expected to follow and on this. Keeping blood glucose levels in bottles is typical in equality. Second factor in this violence will be caused insulin requirements to increase or the less insulin required during that from try to insulin must and always be contribute in the interconnectedness to provide so the dose of insulin should be adjusted for the food intake results of blood glucose and monitoring glucose increasing along with the rising blood glucose and family should know about the increase in appetite insulin dose appropriately as seek medical exercise. Reduce the long plan exercise, cross country running, long distance hiking, cycling, skiing requires reduction of the insulin dose and increase in carbohydrate intake. Lead hypoglycemia may occur during the night or even the next day, but may be avoided by taking a bedtime recovery meal, including slow acting carbohydrate and fats such as cereal with less vigorous exercise such as food session in school and spontaneous play can be managed with reduction in short acting insulin for exercise. Regular exercise and associated fitness increases insulin sensitivity to insulin requirements in a child who takes up new regular exercise may reduce eating too many carbs containing foods such as fetus snacks without insulin and parties or during school. Infrequent and unreliable blood glucose tests, this is a variant of blood glucose levels recorded are inconsistent with age. We will see family disruptions such as divorce with separation and pain disorders affect crisis. Some young people omit insulin doses to induce weight loss. Diabulimia, inadequate family motivation, support, and understanding as children can never have a holiday from their diabetes. They need a great deal of encouragement to achieve blood glucose levels in target. Education programs for children and families need to be arranged regularly and match the level of development. Children should be encouraged to become self-reliant, but with adult supervision until they are able to take responsibility. Special courses and holiday camps are available in the UK. They are organized by Diabetes UK and local diabetes teams. Management of school individualized care plan should be developed by the parents' diabetes team and the school to address the specific needs of child. This will include child anxiety needs, management of hypoglycemia and exercise for younger children. Support is needed to help test blood glucose, calculate and give the pre-lunch insulin injection or bolus from the pump to protein adolescents. Diabetes in young people is influenced by biological, psychological, and social factors, the rapid growth of Puberty is governed by a complex interaction hormone changes, some of which involve insulin and insulin-like growth factors. Growth hormone, estrogen, and testosterone all oppose insulin action. There is increase in insulin requirement from usual 0.5 to 1 unit per kg per day of early childhood up to 2 units per kg per day. The increase may be especially marked first thing in the morning due to the peak of their growth hormone secretions overnight. In early adolescence, young people may learn that they not immediately gain weight, eat less healthily, or miss an injection. This may discourage them from meticulous self-care. In later adolescence, they may feel indestructible. Some test the degree to which the rules can be broken as they feel care. It is then important to focus on immediate benefits to good diabetes care and work with every young person to identify strategies and support them to find solutions. With increasing independence, a young person may explore behaviors such as smoking, use of sexual relationships. Diabetes team need to ensure that joint person understands how to manage this safely alongside the diabetes conflict with parents. Some professionals is common during adolescence and may focus on diabetes management. Many parents are very proactive in finding difficult in process. Some children take responsibility for their diabetes. Support from their teen psychologists and psychologists may be useful. Some young people with diabetes, especially girls, has excessive weight gain, height, weight, and body mass in BMI, should be incorporated at each clinic visit. Intensive insulin regimens can increase the risk of obesity. The weight gain will increase insulin resistance and may have a major impact on your body image. It is unhelpful to lecture about the long-term risk of health, as these are likely to be seen as irrelevant by many young people. However, they may be helped if there are clear short-term goals, especially suggested by themselves. Their efforts to improve their diabetes self-care, to reviewing a satisfactory fluency level are will get properly enthusiastically. There's a united team fusion and biggest guidelines for health and diabetes management. New group support is used to promote health activities that allow groups of young people to aspect while learning about the diabetes management are encouraged. After many years in children and young people's care can be difficult for the patient and family to move to the well-care environment. This transition is helpful in discussing and planning the move well ahead of time by recreational joint clinics with the adult team to through to the early 20s or end of tertiary education. Type 2 children and young with type 2 should have offered support to lose weight and increase physical activity. This needs to be done sensitively with the benefits of improved blood glucose level and cardiovascular health. Extreme metformin should be prescribed with dietary measures with HbA1c of less than 48, 6.5%. In addition to the clinical assessment recommended for children with type 1 diabetes, children and young people. Type 2 diabetes are increased risk of reduced cardiovascular health and should be screened for hypertension and dyslipidemia from diagnosis. Diabetes mellitus and diabetes fully managed by an intensive insulin regimen and natural insulin will calm eating the lifestyle, exercise, and courage. The A is associated with morbidity and mortality and needs continuous management. Long-term complication reduce the HbA1c can be maintained at less than 48 millimoles per mole, 6.5%. Hypoglycemia is a common health problem. Common problem in neonates in the first few days of life, and therefore it is uncommon unless a child has diabetes with CCL. Hence, the mnemonic DBC, energy gain circulation, then DEFG, don't ever forget glucose. It can also be caused by a number of rare disorders. Rare hypoglycemia may cause neurodisability or even death unless recognized treated prompt. It is defined as a blood glucose level less than 2.6 in children without diabetes mellitus. Although development of the feature will depend whether other energy sectors can be present. Simple features, sweating, failure, CNS, signs of irritability, headache, seizures, and coma. Also hyperplasia beyond immediate natal care. Insulin excess exogenous insulin, diabetes mellitus, maternal diabetes, insulin given septiciously and with beta cell disorders, persistent Hypoglycemia, hyperinsulinemia is seen as some of infancy with melanoma, don't reduce sulfonylurea, autoimmune insulin receptor antibodies. And Beckwith Wiedemann syndrome. Without hyperinsulinemia, liver disease, chronic hyperglycemia, of childhood embolism, metabolism, glycogen storage disorders, galactosemia, fatty acid oxidation defects, and hormonal deficiency, growth harmonicity is decreased, and Edison disease, congenital hyperplasia, Dawson aspirin beta blockers, sepsis, neurological sequelae, including epilepsy, neurological impairment. Infants are at risk of hyperglycemia and have high energy requirements and relatively poor results of glucose and glucose and glycogenesis. When cognitive brain was exposed. This is why starvation of infants to know before us preoperatively. Preoperatively should be avoided replacing for with eye replace containing infusions. Causes this neonatal hypoglycemia transient neonatal hypoglycemia it first when it has high exposure to high levels of neonatal massive diabetes or insulin resistance. The infant responds small for gestation age. Persistent hypoglycemia happens in infancy. This demutation causes dysregulation of insulin release by the islet cells of lung enhanced by islet cells of pancreas, leading to profound non-ketotic hypoglycemia treatment like high concentration glucose and diazoxide. As medication will be required to maintain safe blood glucose pending investigation when medical treatment fails. Pancreatic surgery malignancy. Pediatric hypoglycemia is a poorly defined entity in which young children rarely become hypoglycemic following short period of starvation, probably due to limited reserves gluconeogenesis. Child is usually seen on insulin as well. Regular carbohydrates, for example, extra glucose drinks when ill will usually prevent hypoglycemia to condition more spontaneously. Lightweight and dependent metabolic disorders, they may be present with hypoglycemia at almost any age in childhood, but the metabolic would suggest